Yes.
Professor Hay, a handful of questions next on the issue of consent, patient consent. And my questions are going to be essentially seeking to understand the factual basis for your understanding of current and previous practices. In relation to blood samples, you've said in your statement, and this is paragraph 80.3, one did not ask for consent to take blood samples. I think it is assumed that the patient has consented because they go along and allow the phlebotomist to take the sample. It is not normal to take verbal or written consent for blood sampling other than for the purpose of research. Now, I understand your point, Professor, about the patient consenting by allowing the blood to be taken. But do you take that to mean, in terms of your own practice or your understanding of current practice, that the patient is consenting to any and every use of that sample? Or is there some limit to the uses to which the sample can be put?
I think if the sample was to be stored, that would be a separate matter. Although the Human Tissue Act doesn't apply to plasma, as far as I'm aware, but the patient wouldn't necessarily know that, probably wouldn't. I mean, it isn't normal practice to ask for consent, but you would, and in a routine review appointment, you tend to take the same samples each time. And at some point, you might, the patient would often know what the samples were for, because the results would often be discussed. For example, the HIV viral load, the CD4 count, the patients often want to know what those results are because they give them an index of their current status, so you discuss them. If you're taking a sample for something new, depending on what it was, you might describe it in general terms. I know, for example, if you refer a patient with abnormal liver function tests to be investigated by a hepatologist, they won't describe every single test that they're doing, but they'll say, well, we're going to test for some hepatitis viruses and some antibody tests and your liver function tests. They probably wouldn't say more than that unless the patient asked. And if the patient asks, then of course you tell them. But what I was trying to get across is that it is not normal practice to sit down and list every single test that's going to be done and every time and say, is that all right? You see what I mean?
Yes. I think in a sense you've anticipated, I think, two of my next questions. Where you have a patient who is a new patient, or you're doing something which is not the standard array of tests that you may have done many times before and then explained the results, and you may assume that the patient has some, therefore, understanding of the purpose. But would you accept that in principle different considerations may arise, depending on the particular circumstances, with a patient who's not previously been tested or a patient where you're doing something
absolutely.
new?
Because at the end of a consultation with a new patient, you would summarise where you think you're up to. They will probably want to know the range of possible diagnoses, and you will describe in general terms what the tests will be. You know, if someone comes to me with easy bruising, I will give them my personal evaluation of the bleeding history that I've just taken from them. And I'll tell them, we're going to check a few clotting tests. We will probably have to get you back in on another occasion to check your platelet function tests, and you'll tell them they have to avoid aspirin and drugs like that for 2 weeks before the test, and so on. And similarly, if I saw a patient with a mild bleeding disorder that had been long since lost to follow-up, who was new to me and might have been treated with who knows what in another hospital, I would explain to them that we had to test them for hepatitis C. I would give them an evaluation of the likelihood of that test being positive and say, you know, it may well be negative, but we really need to know one way or the other.
And in relation to stored samples, could we look, please, Shumik, at WITN 3289054. If we go to the second page, now this is a specific form at Manchester Royal Infirmary in relation to genetic testing, but if we go on to the next page, we can see it seems to be an information sheet for patients. It asks the question, what's the purpose of obtaining a blood sample? And then if we go over the page, it provides information about where the sample will be tested, how long the sample will be stored, and then if we go to the next page, what else might be done with my blood sample. Now, I appreciate this is a leaflet specifically concerned with the taking and storage of samples for genetic testing, but would you consider that those kind of questions, where will it be stored, how long will it be stored, what else might be done with it, are the kind of questions which patients should be given information about if samples are going to be stored?
Genetic testing was considered particularly sensitive, and this is the form that we actually give to them before we go through a formal consent process. And there was this leaflet was submitted to you as one of the exhibits to my response, as was the consent form. As the consent form says, it is our plan to store your sample indefinitely, which is unusual actually, because that means even after the patient has died, we may continue to store that. And the patients are asked to consent to that in writing. Now, that's not for research purposes. That may be to facilitate testing of relatives at some stage in the future. This leaflet and the accompanying consent form were actually designed by the Genetics Working Party of UKCDO. Again, it's considered, I don't think this is really a very good example, because the status of genetic testing is in general a little bit different. I think if we were to store samples for potential research in the future, some form like this would be appropriate, but UKCDO certainly don't do that, and I don't have any research samples stored away either. Research repositories have to be regulated, and a form like this would be appropriate for that sort of purpose.
And what about, maybe this is hypothetical if you don't do it, what about storing samples to keep essentially on the basis that there might come unknown viruses in the future that one might want to, or other unknown issues in the future where one might want to take the sample out and test at some future stage? I mean, is that, first of all, is that something that happens at Manchester in your sector?
Well, all virology departments, as far as I'm aware, store samples for 3 years and then dispose of them. And that's in case they need to investigate further. One of the other principles you will have noticed going through the consent process in relation to genetic testing is the principle that if we want to retest the sample for a different condition, we would have to go back and ask the patient for consent again, because the consent is extremely specific. And in the first part of the consent form, you explain to the patient that you are only going to test for the named condition, which will be haemophilia A, B, or von Willebrand's disease, or whatever, and that you won't be testing for anything else, so that they understand that you won't be digging it out and using it as a research thing without their permission. And we say quite explicitly to the patients, if we want to do that, we are obliged to come back and ask you. Because, for example, once we have a stored sample of DNA, we could, in theory, test that sample for cancer genes. I'm just using that as an example. And the implications of testing for something that might give you cancer are very different from the implications of testing you for a hereditary bleeding disorder. And so the patient may be very happy, has often volunteered to be tested for the familial gene, but might prefer not to know if they have a gene that predisposes them to cancer. So it's an important principle that applies to genetic testing. Now, by the same token, I think if you stored a sample and you wanted to do research on it, you'd have to go back to the patient. I mean, I think that's the current view. I don't think it has always been that, but I think that even if you've got a sample stored, you may have taken general consent that you have a sample stored for research purposes, and in some cases that consent includes consent to keep the result anonymous. That would be one way of handling, for example, testing for a new antibody test, where you may not know what the implications of a positive test are, or indeed how good that antibody test is. And then it's helpful to test a group of patients anonymously on the understanding, explained in advance, that the patients will not be told the result.
So by anonymous, you don't mean without identifying the individual, you mean without telling the individual?
Yes, that's right, and keeping the report anonymous as well.
Yes, well, I understand that last. It was just the use of the word anonymous. I just wanted to clarify.
Yeah,
Thank you very much.
Sure, all the reports would be anonymised, but you clearly need to identify the sample.
And then moving on then to the question of hepatitis C testing, you say in your statement this, it has never been customary in any branch of the health service to provide pre-test counselling or obtain specific consent for hepatitis C testing, hepatitis A testing or hepatitis B testing. And then you refer to information received from your hepatology colleagues that in 2020, if they saw a patient with abnormal liver function tests, they'd arrange a battery of blood tests which would include viruses such as HCV and would tell the patient words to the effect, I'm doing a few tests, including tests for viruses. Now, I just wanted to explore with you what the factual basis is for that, your belief that that's the customary position. Your own practice, as I understand it from your evidence so far and your written evidence, is that you, I think you say almost invariably or invariably, did tell patients that you proposed to test them for hepatitis C, thus affording them presumably an opportunity to decline.
Well, I can't remember anyone declining, though they have recently when we've chased them up, sort of the odd patient. Well, I think this circles around what you mean by counselling, to be honest, because my understanding of the questions being put to me in my Rule 9 request was that a comparison was being drawn between the situation of formal counselling for HIV testing and hepatitis C. And my answer was in relation to that, because whilst I would certainly tell people I was testing them for hepatitis C, the implications of that test are not the same as for HIV. And indeed, the process of counselling people prior to HIV testing really only fully emerged a year or two after we started to have a test. Because, to be honest, back in 1984-85, when testing first became available, the implications of the test were not fully known. So, the conversation could be quite short and would include assertions such as just having HIV doesn't mean you've got AIDS, because we didn't know the natural history and so on. We didn't realise that it would have major implications for getting a mortgage, for getting life insurance, and all of those have to take their place in the process of counselling to have an HIV test once those things are known. Now, with hepatitis C, we knew that the natural history was a prolonged one, that a significant proportion of patients would have a very good prognosis, whilst a significant minority would obviously get serious liver disease. So, it would be a different conversation. So I'm not saying that you would. I think in our practice we probably talk more to our patients about hepatitis C prior to testing even than the liver doctors do, because the liver doctors see lots of people with abnormal liver function tests. The commonest cause of abnormal liver function tests in the general population is obesity. Now, in my group of patients, that's sadly not the case. If I see a bleeder, my concerns are slightly different. If they've got abnormal liver function tests, I would assume it was hepatitis C until proven otherwise.
So if you were, in 2020, seeing a patient, perhaps one of the infrequently treated patients who've been lost to follow-up, who has now come back to the centre, and they either haven't been tested for hepatitis C, or you don't know whether they've been tested for hepatitis C or not, and you thought it would be prudent for them to be tested for hepatitis C, what information would you typically now give that patient in advance of undertaking the test?
Well, some of these patients are already concerned because you've dragged them out of the woodwork, and they're worried that you might be giving them bad news. And they may have very little awareness of hepatitis C, because I think there is much less awareness in the general public of hepatitis C than there is, for example, of HIV. So you have to introduce to them the possibility, having taken whatever treatment history you can elicit, that there is a possibility that they may have contracted hepatitis C. As I say, you would make some sort of calculation based on what you've been told. You might not be able to assess the risk, but you have to put that to them, and then you would say, I think we need to test you. And they will almost invariably say yes.
And so that would be your practice in 2020. Was your practice in 1992, 1993, 1994 any different from that?
No, not really.
And so the basis for if we leave aside pre-test counselling in the way in which you've described it, the basis for the statement in your witness statement that it's never been customary to obtain specific consent for hepatitis C testing, are you there talking about written consent, or are you there talking about the practice that hepatologists' colleagues tell you that they just say, well, we're going to test for a range of viruses without saying any more?
Well, we certainly didn't get written consent. We do get written consent for genetic testing, but not for any other tests, unless they're invasive, of course.
In relation to HIV testing, I just wanted to understand your understanding of the current position. You've said again, I think it's the same paragraph of your witness statement, you say that unlike, talking about HIV, you said unlike HIV, which almost uniquely requires pre-test counselling during the 80s, 90s and until fairly recently. And then the impression your statement gives is that the current practice in relation to HIV testing would not necessarily involve the patient being told they were being tested.
Well, that's my understanding. I mean, I personally haven't tested any new patients for some time. If someone came out of the blue and their last treatment had been during the period of risk, I would still go through all of that business. But at the beginning, I'm sure you appreciate, different clinicians had very different approaches to imparting someone's HIV status to them. I felt that Professor Preston's approach was a very good one, and some of my colleagues not so good. And then it became universal practice to carefully counsel people before they were tested. And I only mention that because I think that the implications have changed with time, because the treatment is very much better. Very few of our patients have died from HIV since 1995. Life insurance is also less of a problem. I mean, at one time, if you had asked for a house loan above a certain level, the insurance company would insist you had an HIV test. I've been HIV tested twice myself on that basis, and my GP told me that half the residents in Lynn had had an HIV test for that reason. And he counselled me, despite the fact that he knew I was a consultant haematologist. So I've seen both sides of this, shall we say. But all pregnant women are tested, and you know, so practice does change.
Wanted to then ask you about some of your evidence yesterday in relation to life expectancy. So this, Professor, was in the context of having asked you what consideration was given at Sheffield in 1983, 1984 to the possibility of reverting to cryoprecipitate more extensively, at least for a period of time. And you referred, when giving your evidence about increased risk of death and from hemorrhage and decreased life expectancy, to a paper by Dr. Ritzer. And I wanted to check, first of all, that I got the correct one. WITN 3289047.
Haemophilia treatment in the UK from 1969 to 1974 British Journal of Haematology, 1977.
Now that's the document we asked you to read over lunch, which I'll come on to. But first of all, yesterday your evidence was that this was a potentially relevant piece of material, and this is one of the exhibits to your witness statement.
Yes.
And we can see it's by Dr. Ritzer and Miss Spooner, treatment of haemophilia and related disorders in Britain and Northern Ireland during 1976 to 1980, report on behalf of the directors of haemophilia centres in the United Kingdom.
Yes.
And if we go to the second page, right-hand column, please, Shumik, under the heading Age at Death and Causes of Death. I wanted to check whether this was the material that you were referring to, Professor Hay, as relevant to the assessment being made in Sheffield in 1983 and 1984. So we'll see under the heading Age at Death and Causes of Death. Could we scroll down the page? Thank you, that's perfect. You'll see it says in that first paragraph, in the last two sentences, the average ages of the patients who died were 46.7 years in the haemophilia A group and 48.3 years in the haemophilia B group. Comparable figures for 69 to 74 were 42.3 years and 33.6 years respectively. And then if we go to the next paragraph, please. It said a more useful statistic was the median expectation of life. So I think it's easier if we just go back to how it was before. Thank you. This was calculated from life tables. It says, surprisingly, the calculations yielded a median life expectancy of 69.1 years for severely affected haemophiliacs as compared to 72.8 for normal males. Those figures must clearly be viewed with caution, since the numbers in the calculations were relatively small, and also because of the possibility that deaths in haemophiliacs may not all be reported to haemophilia centre directors. And then there's reference to the number of deaths due to cerebral hemorrhage in the following paragraph, 26 of 89 deaths, 29%. Now, first of all, is that the report or study that you were referring to in your evidence yesterday?
Yes.
And what is it that you drew from this report when this issue... first, sorry, I'm going to start that again. Was this something that was expressly considered in 1983, 1984, when the question of how to respond to the AIDS crisis may have been being discussed in Sheffield?
Well, it was published in 1983 in March. The perception certainly was that the introduction of concentrate had significantly improved life expectancy. Now, in the paragraphs you've just quoted me, they compare the average age of death, which is not quite the same thing as life expectancy, but they compare it with the previous report from Rosemary Biggs, which you suggested I should read over lunch. Now, Rosemary Biggs doesn't use actuarial methods or life tables, so the average age of death is the only metric for comparison, and I'm sure you're going to point out to me that it has gone up relatively modestly.
Yes.
I think, though, the headline figure that people took away was the median life expectancy of 69.1, which has been much quoted since. Of course, Rosemary Biggs was not the only source of data. There were other studies showing the average life expectancy at that time was about 40, but back in the 60s and very early 70s. But it is quite difficult comparing all these things because people use different methods. I've recently written a review which is about to be published in the Journal of Thrombosis and Hemostasis on mortality in haemophilia. And this is a difficulty that besets the whole area, it's actually quite difficult to compare. Now, one other thing I'd say about the comparison between these two is they report adjacent periods, and the second report from Charlie Ritzer is reporting a period during which concentrate is being introduced and patients established on home therapy. So you would perhaps not expect a really dramatic difference, because in terms of the therapeutic approach, the two periods overlap somewhat. What it's showing is a trend towards improved life expectancy that would not flower fully until the period after 1980, when most people were established on home therapy.
And if we just look at the Biggs report, because you've got the benefit of it and I have, but others watching don't, so I'll just put it on screen. It's PRSE 304645. Shoemake, it'll be in the knowledge of risk material, so you may have it stored in a separate location.
It was part of my submission as an exhibit, actually.
We now have on screen, I know you've got a hard copy, Professor, the Biggs report, and so we'll see that covers the period 69 to 74. And if we go to the fourth page of that, please, Shoemake.
Well, can we just stop at the first page?
Yes, back to the first page, please.
And underneath the summary, just the very first sentence, because before round about 1960, as one understands it, the life expectancy of a haemophiliac suffering from severe haemophilia was probably in the region of 20 to 25 years. It hadn't gone up very much since the 1930s. It's gone up a bit, but not much. That's probably about right, is it?
Yes, it's about right. It's life expectancy was about 29 years. And it improved a lot from the no treatment era, when it would have been about 10 or 15 years. And so from the 50s, they would have had blood transfusion and plasma, and cryoprecipitate was introduced in the mid to late 1960s.
That's why I think Rosemary Biggs is referring here in the first sentence, is it, to 1967? Because that's when cryoprecipitate would have been introduced.
Yes, widely. I think it was described in 66.
Yes. So the first sentence she says is observational. It expresses an opinion. Is that an opinion you would agree with, that increasing amounts of cryoprecipitate and of factor 8 or factor 9 concentrate have greatly improved the prospect for treatment of patients suffering from A and B?
Yes.
Thank you.
Unquestionably.
So, unquestionably, the introduction of cryoprecipitate then, and later we know that concentrates, the NHS concentrate from probably about 1970 onwards, we're informed, formed an increasing part of treatment, and then commercial concentrate when there wasn't enough NHS to go around from about 1973 onwards. That, I think, is broadly the position, isn't it? As you understand, you weren't practicing at the time, so this is all done by report, so I'm putting a very broad picture to you. I'm not going to hold you to a point answer, but that, I think, is broadly the understanding.
I was a medical student at the time, but obviously have gone into the history.
So you were going to go to the fourth page,
yes.
Ms. Richards, I'm sorry.
And to draw attention, in particular for the benefit of those who are listening, because Professor Hay has a hard copy, to the top of the page, in the early statistics, the average age of death of severely affected haemophilic patients was less than 20 years. Thus, the age at death seems to have more than doubled as a result of factor 8 therapy. And of course, I think we know broadly that in the period she's here looking at, up until 1974, the majority of factor VIII therapy would have been cryoprecipitate, although, as you've just observed, of course, concentrates were starting to be used and were then used much more increasingly in the years that followed.
Yes, I mean,
Yes.
the precise amounts of cryoprecipitate compared to the precise proportion will be a matter for us to explore elsewhere, but it's I think broadly what you've said must be right.
Yes, absolutely, and you should get those figures that we have in the UK CDO statistical response to their Rule 9.
Thank you.
And then we can see reference in the table into the age at death of patients having haemophilia A or B, and for present purposes I'll just look at haemophilia A, and we can see there the average age at death 42.3, and whilst we're looking at it just to observe, we also see the number of deaths from intracranial bleeding, which, and the figures in both reports are fairly small, but it's 16 out of 62, which would be, I think, approximately 25-26% of deaths from that cause in that period. So, is this, and this is looking at it very broadly, Professor Hay, but is this right before the availability of any form of factor VIII therapy, and so before the availability of cryoprecipitate, the average age of death was around 25 years or so. But according to Dr. Biggs in this, it almost doubled during the period 69 to 74, when most of the factor VIII therapy producing that result would have been cryoprecipitate.
I think my interpretation of what she's saying is that it doubled from the period before cryoprecipitate to the period that she's looking at.
Yes.
Because the use of cryoprecipitate was already well established in 1969, I think.
And then when we look at the period covered by Dr. Ritz's report, we can see that the average age of death increases again, but it's by a much smaller margin, around 2.5 years.
It's about 10%.
I agree with that. And to be honest, I think the actuarial calculation paints a much rosier picture, but you can't use that to compare it with the earlier period because there isn't a similar calculation in Rosemary Biggs' report. And I think that the period that Charlie Ritzer is reporting is a sort of intermediate period because it's a period during which some centres are quite well advanced in converting to concentrate and others much less so. I know from the history of the Manchester Centre that there were still patients being treated with cryo in the early 80s, and whilst I appreciate that they were unusually conservative in their approach to treatment in the Manchester Centre, it was a more gradual process than I had realised. Yes.
And so would this be fair that these two reports don't provide any significant support for a conclusion that reversion to cryoprecipitate in 1983, particularly for a relatively short period of time, maybe a couple of years, would have led to a significant increase in deaths or a significant decrease in life expectancy?
You are asking in the absence of HIV infection.
Yes. Yes, we know, of course, as well established in later reports, including those co-authored by Professor Hay, that as a matter of fact, the greatest impact upon mortality in the years that followed was viral infection, HIV.
Yes, but people would not have known that at the time for the purposes of this comparison.
Well, I think I would agree that the increment in life expectancy between these two reports is relatively modest. It's not insignificant. and you also have to recognise that the second report is an intermediate period when there are still a lot of patients being treated with cryoprecipitate, and not everyone has been established in home therapy. You will see that if you look at the reports of the prophylaxis and the home therapy working parties from the 70s and early 80s. I was unaware until recently of the existence of this working party, but they did actually audit the rollout of home therapy, and it was slower than I had realised. I think my view was rather coloured by my personal experience in Sheffield, and I had assumed that all other centres were as quick to do it as they were, but that is actually not the case.
So I'm going to move on to a separate topic. Before I do so, was there anything further that you wish to ask
only this really. I just draw your attention to the risk, I think, or the cause of death proportionately, which Dr. Ritzer in his paper identified as being intracranial bleeding. I think it was about 29%, he said, of the cases that he was looking at died of that if they didn't die of other causes. If one takes the 16 that we're looking at, table 3, the first item, intracranial bleeding, and then the total number of cases, 62, it's about just over 25%. It would be 25% if it was 64. So it's just over 25%. But there's not a great deal of difference in those two figures for what it's worth. Is there?
No, true, but I agree, and intracranial bleeding was the commonest cause of death during that period, but I would come back to the fact that, you wouldn't expect a dramatic difference looking at two periods when in one case everyone is treated with cryo, and in the second you have a transitional period. They're not all on home therapy during this second period, or not for the whole of that period. I can tell you that the number of patients dying from intracranial hemorrhage now is less than 10%. So treatment with concentrate as currently practiced, and with prophylaxis, which may of course be very, very important, because you will expect to prevent a lot of the bleeds that might have occurred with treatment on demand, but we have reduced that complication quite dramatically.
I can fully understand the significance of prophylaxis, but just comparing these two sets of data, for what it's worth, as you've indicated, they're not exactly comparable. What we're looking at on the screen at the moment, the Biggs paper, is at a time when there was some, but very little, home therapy, I think. Am I right?
Yes, I think that's correct.
So the two changes were, wasn't just the change from a little factor VIII to a concentrate to a lot of factor VIII concentrate proportionately, but also a change from a little home therapy to a lot of home therapy proportionately, and you still have a fairly comparable death rate in these two studies over the two periods, so far as intracranial bleeding is concerned. It doesn't allow for any dramatic distinction between the two, does it?
No.
Thank you.
Professor Hay, I've got a number of questions now that I've been asked to ask by core participants, and so we're going to dot around from topic to topic rather than follow a chronological or thematic order. The first arises out of a passage in your statement about research where you describe the difference between an interventional study and observational research. And your statement explains the different ethical requirements that might attach to each. Is the distinction between an interventional study and observational research always clear-cut?
No, I don't think it is, actually. It may be a matter of opinion. We recently conducted a study internationally, not UKHCDO, by the way, but investigator-led study, which involved applying a number of quality of life questionnaires to the patient at intervals. And they had to give consent to this anyway, because, written informed consent. But it wasn't regarded as an interventional study in 6 out of the 7 countries. And the 7th country was France. And in France, they said, well, if we'd asked fewer questions, it would have been an observational study, but they regarded it as an interventional study because it took the patients more than an hour to fill out the forms. And I think that illustrates a classical grey area. I mean, I can see their point, but that came down to a matter of judgment. There are other studies where you may record the results of interventions that are clinically indicated, and that should make it an observational study because the intervention would have occurred anyway. For example, an operation or a blood sample or whatever. And the intervention's not being done for the purpose of research. And because it's not being done for the purpose of research, that would be an observational study. But if you were to test a new agent, such as a new factor VIII concentrate, to establish safety and efficacy, that's unquestionably an interventional study because the patient wouldn't be given that agent if they weren't participating in the study. But once that same agent is fully licensed and you start to prescribe it in the normal way, when they participate in a post-marketing surveillance study, that's an observational study because they would be having that agent whether they were participating or not.
Is there a risk?
May I just ask a question? Yes. Just going back to the start of your answer there, you were describing where the intervention would have been done anyway, and you're simply observing the effect of it. That would be observational. One of the situations I've come across on a number of occasions in cases which I've had to determine in the past have been cases where there were 2 possible forms of treatment, one conservative, the other interventionist. Both were entirely proper as a matter of practice, but the choice was that left to the clinician. If the clinician chose the interventionist and had in the back of his mind that this might be a benefit to research, which he was particularly interested in doing, would that make it interventionalist or observational?
Well, that's an interesting question that speaks to the intent of the person in question. That's a really grey one because if he was influenced by the fact that it was being studied and that introduced bias, that's actually a problem because it affects not only the ethics of the study, but also its interpretation. because you want to avoid that sort of bias. That is the advantage of a randomized comparison, because then you have negated any biases from the operators. And randomized comparisons are always interventional by definition, but can be difficult to conduct. I conducted a randomized trial comparing high dose with low dose immune tolerance, for example, in 17 countries. And the biggest difficulty that we had there was that we were doing the study because so much was unknown, but nevertheless, clinicians around the world had very fixed views. They were all convinced that they were doing it the right way. And if they had, we wouldn't have needed to do a trial. So many refused to participate because they disagreed with our protocol. What can you do? Difficult.
And picking up from the chair's point, Professor.
No, it's a question, not a point.
Sorry, question. Is there a risk that observational research, or the undertaking of observational research, the desire of a clinician to follow that through, might lead a clinician to keep a patient on the same treatment rather than changing to what might have been a safer treatment?
I think that's unlikely. That would be really unethical.
And in the early mid-80s, and I think you were engaged in research from roughly 1983 onwards at Sheffield, but in that period of time, in the early and mid-80s, what were the safeguards against clinicians undertaking something that was unethical, or safeguards that might address some forms of subconscious or unconscious bias?
Well, subconscious or unconscious bias is a problem in research anyway, throughout, which is why the strongest evidence is always considered to be the results of a randomized controlled trial. Not that that trial design doesn't have weaknesses, because it is often criticized because the subjects that participate in such a trial are selected. But it's the most reliable way of excluding bias. Occasionally, you can also exclude bias by following natural experiments. And one example of that is an observational study that we conducted between Scotland and England, looking at the effect on the immune system of different types of concentrate. Now, in those situations, the whole of Scotland used a Scottish high purity product that had been prepared in one way, because that was what was available to them, and the whole of England used different materials. So just through circumstance, you had two groups that were all treated in the same way, and that offered the opportunity to compare the two in a way that the next best thing would have been to randomise. And incidentally, the participants were, although it's an observational study, we had to collect a lot more data than would have been normally the case. So they were consented in the same way as they would have been for an interventional study.
But do you know?
The thing to do, to be honest, and this is what we try to do currently, is to assess each case individually. And to make a judgment, is this an observational thing? If you have to take additional samples, or you're doing something burdensome, then it becomes interventional and you have to get consent for that.
Do you know, in that period at 83 to 87 when you were at Sheffield, and I appreciate you were the junior to Professor Preston and Dr. Greaves in terms of your role at the time, but do you know what, if any, ethical approval systems or other safeguards there might have been in place at that time?
The details have changed over the years, but the basic principle has been the same throughout this period. That is, if you want to do a clinical trial, you have to take it to the ethics committee. They have to approve everything, not least the patient information and the consent form. They have lay members on every ethical committee, and they take a particular interest in that area, as you might expect. They also have statisticians on an ethics committee. So, for example, if they consider that the trial design is inadequate, then they could, that is an ethical issue. It is unethical to do a clinical trial that is inadequate to answer the question, because it potentially puts, in theory, it would possibly put patients in harm's way without having any hope of answering the question, and that would be considered unethical. If you want, if you participate in a clinical trial of a new product, for example, the alphanate trial that was conducted in Sheffield in 1984, all the participants would have been consented.
That's the, I think the trial that you referred to yesterday, is it, with the heat-treated products?
Yes.
Did you have any involvement in that trial yourself in terms of selection of patients and know what information was or wasn't given to the patients?
I don't remember much about it, because it covers a period when, for part of that time, I was at the Children's Hospital, partly because I was moving about. They got the other senior registrar to get more involved, and her name is actually one of the co-authors. My recollection is that patients were given an information sheet and had to write consent.
Moving to a different topic. No, actually, sorry, before leaving that trial, would that trial have gone before any kind of ethics committee for approval?
Oh, yes. Yes. At that time, there would all have been hospital ethical committees. Much later, they introduced a system for national approval. So you go to an MREC, and they're arranged regionally for multi-centre trials involving more than 4 centres. But even when you get national approval, you still have to take it to your local ethics committee and your local R&D department and get approval from both of them before you're allowed to start.
And then moving to a completely different topic, in your capacity as a hospital haematologist responsible for the blood bank, which I think was when you were at Liverpool, did you ever become aware of any ongoing issue about HBV infection and pools contaminated with hepatitis B?
No, I can't remember.
Then this morning I asked you about the notification process in relation to variant CJD. Do you know whether there was any, in earlier years, any notification system to UKHCDO of suspected contaminated batches, contaminated with HIV or with non-A, non-B hepatitis C? Was that something that used to be drawn to the attention of UKHCDO directly?
We had an adverse event working party and an adverse event reporting system, which I will be describing to you in greater detail in the final chapter of our UKHCDO Rule 9. And that collected adverse events, including any new reports of hepatitis from the early 1980s onwards. I was a member of that committee. The data was collated by the National Haemophilia Database. We do report adverse events that we think that are specifically related to a product, to the manufacturer, so that they can satisfy their regulatory requirement to report it on to the regulators, that's the European Medicines Agency and the Food and Drugs Administration. This has resulted in the withdrawal of some batches, which seem to be giving lots of reactions, for example. The investigation of new reports of hepatitis after about 1988 all proved to be false reports, insofar as it was genuine hepatitis, but not a new diagnosis. You can imagine that we were particularly keen in the years after 1985, when products had been introduced that were marketed as only hepatitis reduced, to evaluate any further episodes of hepatitis sneaking through. And there were certainly reports with some products in Canada as late as 1988 of some of the virally attenuated products transmitting hepatitis C, and hepatitis B seemed to be more difficult to eradicate than hepatitis C. But then, on the other hand, all the donors were tested for hepatitis B from probably the early 1970s. So the only patients who would have got through that testing net would have been those who were in the window period at the time that they donated. That is to say, the period when they were incubating hepatitis B but had not yet become positive for the tests. The window period, which we haven't discussed so far, is a problem with all viruses, and another one of the reasons why we wanted to get away from plasma-derived products. And if you go through this period from the 80s through to, well, the present day really, you will see that donors are being subjected to more and more tests of increasing sensitivity to progressively reduce that window period. And of course, donor selection is also very important with all of that. And the other thing that's really important that we haven't talked about before is repeat donation, because the safest donor is a donor that repeatedly donates. If you go back to the early 1980s, 50% of UK blood donors were first-time donors, and often the only time they donated. They may only have donated once. And if you test those for viruses, you'll find most of the positives will be in first-time donors. So they're the most risky donors. The safest donors are donors who come repeatedly, and of course they're tested every single time. By the end of the 80s, at least 90% of blood donors were repeat donors. And in the commercial sector, people encouraged that to So these days, most plasma is actually derived from plasmapheresis donors who can donate far more frequently because they're only donating plasma, and they can donate as often as once a month. Anyway, I think I've drifted off the subject a little.
But, may I just ask a question?
Yes.
Yes.
You were going back to the early 1980s, and you say that 50% of the blood donors then were first-time donors, and most of the positives were in that group. If you're talking in terms of positivity for hepatitis C, or non-A, non-B as it was, how do you know?
Well, that's a good question. You'll see in my report, and in fact in some of the exhibits, the exhibit you showed me earlier, which has the proposal to the Department of Health for the Hepatitis C lookback, reviews this evidence quite well, I thought, rereading it. In the early 80s, there were a number of studies trying to assess the frequency of non-A, non-B hepatitis, obviously without a specific test. And the way that they approached it was they saw how many recipients of multiple blood donations subsequently developed hepatitis. Now, these would be patients undergoing, say, open heart surgery or some other surgical intervention that required a large blood transfusion. So they would be exposed to a number of donors as a consequence of that. So you could evaluate how many donations they've been exposed to, and then you see what percentage of them develop non-A, non-B hepatitis thereafter. And from that, you derive a figure for the number of the donors that were infectious for non-A, non-B hepatitis. Now, clearly, that's methodology is relatively soft. And you'll find somewhere in my exhibits there is a table. I know you're going to subject this to independent statistical analysis, which shows the risk of contracting non-A, non-B hepatitis based on the number of donations that you're exposed to. And it gives a range of percentage. The average is about 0.75% of blood donors being infectious for non-A, non-B hepatitis in the very early 80s, based on that methodology. But it varied. There were a number of papers that looked at this from different countries. And of course, we do know that the incidence of hepatitis C varied from country to country. It was higher in America than in the UK, and higher again in places like Italy and Japan, for some reason, also have relatively high rates. So the rate will genuinely vary from country to country, but based on that soft methodology, in the early 80s, we think it would have been between about 0.5 and 1%. Now, there are papers later on in that decade from Contreras et al., which I also quote. Once they had a test, they were able to assess the prevalence in the donor population accurately, bearing in mind also that the donor population is not a cross-section of society. There are certain ethnic groups that donate less, which is actually a practical problem because there are ethnic differences in the frequency of blood groups as well. So that does give rise to practical problems. When I did my transfusion training, for example, blood donations from people from the Afro-Caribbean community were coded so you could identify them, because they were particularly useful if you had a patient with sickle cell trait, for example, who needed a transfusion. Anyway, I'm drifting again.
Well, the question, if I can take
Contreras paper.
Sorry, you couldn't tell me about Contreras paper. I'm sorry, I'm interrupting. My apologies. Please.
Okay. But the Contreras paper showed a tenfold reduction relative to those early soft assessments. And this was attributed to the introduction of donor selection. Now, although donor selection, this is pre-donation exclusion. This is the process whereby all prospective donors have to read a leaflet, and if they fall into the following risk groups, not donate, please. Of course, although this was directed at the reduction in the risk of HIV, there is an overlap in the risk groups for HIV and hepatitis C, clearly. So donor selection dramatically reduced the risk of hepatitis C as well.
Just going back to the start of your answer, the question being really arising out of your comment that about 50% of the donors would have been one-time donors, and that they were the ones who created more of a problem than the regular donors back in the early 80s. Suppose that you had, as your first example was, surgery involving quite a number of transfusions. Suppose, let's say 10 bags, 5 from 5 first-time donors, 5 from other donors. How would you know which bag contained the infection if the person who was having the surgery actually later on developed and showed signs of hepatitis non-A, non-B? That was the point I was trying to understand.
I see. Well, in the absence of a test, you wouldn't necessarily. You could go back to all those donors and test them for what you knew about, see if any of them had chronic liver disease, and take a history.
What was that done? Do you know?
There were laterally look-back exercises conducted by the transfusion service, but they did not occur until after hepatitis C testing became available. And they were really directed at people who were repeat donors who turned out to be positive for hepatitis C. Then they went back and traced the recipients of previous donations.
Yes, I understand the repeat donors. It's the one-time donor and their infectivity, which I was really trying to understand.
The one-time donor you couldn't do anything about.
Does it come down to the fact that's an estimate really, which you've given us, which has, as far as you know, no basis in the literature?
Sorry, I don't understand.
It's all right. It's probably more of a comment than a question. That's all that I need to ask. Thank you very much.
So I've got some questions still, but I note the time, and I think it might be sensible to have a break, and then I can complete the questions.
Yes, of course. Council will. She needs to field questions from people who aren't here to talk to her and give her further questions, because you'll appreciate that Council to the Inquiry asks the questions in an inquiry, and in general, core participant Council don't. That's a generality, but it's likely, I suspect, to be true in this case, particularly when they're not here in any event. So she'll take some time just to do that. How long do you think you need?
I've got most of the questions, sir. There's only a handful I haven't been able to consider, so half an hour would be ample. But that will give Professor Hay an opportunity to take a break, and those watching an opportunity to take a break
yes,
as well.
so we'll have a cup of tea and come back at... would 4 o'clock be all right?
Yes.
4 o'clock be okay? 4 o'clock.